January 14th. We have two substantive agenda items today. The first is an update on the ACO regulatory rule, Rule 5.0, which Marissa Malamed will walk us through. And then second, we have an update on the resubmission of Brattleboro Memorial Hospital's budget and its financial reimbursement for 2026. So I will start by turning to Ms. Malamed.
Great. Good morning. I think my slides are loaded. Can you see them?
Yes.
And hear me okay? Great. So good morning. I'm Marissa Malamed, and I'm here today to share the final proposed Rule 5.0, Oversight of Accountable Care Organizations. You last heard on this topic from Michelle Sawyer, who has moved to a new position at the Green Mountain Care Board with our data team. And so I'm taking over as shepherd of this process. I want to thank Michelle for her impeccable organization and helping me get up to speed on this. I'm also assisted in this process by Mark Henksler from our legal team, who can help me with legal questions today if they arise, and Angela Pellegrino Wood, our policy analyst. I will start with an orientation to where we are in the rulemaking process and what is left to do. I also have two changes to the rule to present to you today. Then there will be time for any board questions or public comments and a vote on the final proposed rule if you choose. Here's a timeline of the process completed to date. The draft proposed rule was posted on October 1st, 2025, and public comment was opened. Michelle presented the new rule to you on October 8th. That hearing is available on the Green Mountain Care Board YouTube page if you want to review the full rule. And the board voted to proceed with formal rulemaking on October 22nd at the end of the first public comment period. Michelle presented the draft proposed rule to ICAR, the Interagency Committee on Rules, on November 10th. The rule was then filed with the Secretary of State and posted by them on December 3rd and disseminated to newspapers. And those the blue text there is all links to the materials from the various meetings. We then opened a second public comment period, which started December 15th and will run through January 23rd. A required hearing is being held today, and I'm going to share two changes that have come up as we've worked through this process. Following a board vote on these changes and the end of the comment period, the final proposed rule will be filed with the Legislative Committee on Administrative Rules and then again with the Secretary of State. LCAR has a review period, I think it's 45 days, where we may appear at their meeting, and the rule is expected to be finalized in early March. The rule would go into effect July 1st, 2026. And the period from March through June, the Green Mountain Care Board will develop and approve guidance and forms that are necessary to facilitate compliance with the rule by the regulated entities and create a format for Green Mountain Care Board review. So this slide is an overview of the changes to the rule and was shown in a previous meeting. So I'm not going to go over the full changes to the rule. Michelle did an excellent presentation on that on October 8th. You can watch the YouTube video for anyone that wants to see the full review. But as a reminder, in June 2025, Governor Scott signed Act 62 into law. This act, among other changes, modifies how the Green Mountain Care Board regulates ACOs and operating in Vermont per 18 VSA 9382. And the major changes of the rule are in the green boxes there, that now all ACOs in Vermont must be certified by the Green Mountain Care Board, and only ACOs contracting with Vermont Medicaid or Vermont commercial payer must have their budget reviewed by the Green Mountain Care Board. And there's also a new regulatory fee structure. The change in the statute is what necessitated the board to update its rule to align, and it was developed as the landscape of ACOs and how ACOs are present and operate in Vermont has changed over time, as well as removing references to the federal all-payer model that was named in the statute in the rule. But the two changes that I'm going to go over with you today are the addition of a de minimis exemption and also a sort of a process change, actually a change that we had added in the October draft, but then realized we needed to take out. And I will describe both of those changes to you. So the first is the de minimis exemption. With the emergence of more Medicare-only ACOs and learning more about how they appear and operate in Vermont, staff recommend adding a de minimis threshold to the definition of ACOs. So here are the line edits for how we did this. In section 5.103, we added a definition for operating in Vermont to include a de minimis threshold of more than 50 ACO attributed lives. So it would mean that the entity contracts with one or more Vermont providers and have more than 50 Vermont residents attributed through Vermont providers. This number, the 50 threshold, was arrived at by using a formula of 1% of CMS's minimum required number of assigned beneficiaries for Medicare Shared Savings Program ACOs of 5,000 total. And we've had one ACO reach out to us that expects to have about 30 to 40 attributed lives in Vermont through their arrangements with long-term care or skilled nursing facilities, where a minimal number of Vermont lives attribute to Vermont providers. Also, to facilitate this change in line or section 5.104 applicability, we added the phrase an ACO must be certified by the board to operate in Vermont. All ACOs wishing to operate in Vermont. It used to just say all ACOs. So we wanted to clarify what it means to operate in Vermont. The benefits of a de minimis threshold are reduced regulatory and administrative burden on entities and the Green Mountain Care Board for entities that have minimal activity in Vermont and likely are in Vermont on a small scale due to association with larger out-of-state entities. The drawbacks of a de minimis threshold, would be there's no visibility into that ACO with a small presence, and they could grow. We're relying on the entity to report if and when the attributed lives are expected to increase past 50. Attribution can fluctuate, so we're relying on them to report. However, we do have means of we can monitor through CMS ACOs that show on the CMS data that they have activity in Vermont. We've done in the past, reach out to them, and they're always, very communicative to explain what their presence in Vermont looks like. And then a note on this as well: ACOs that are required to be certified would pay the fee. ACOs that do not require certification do not. So that is the first change, and a new version of the rule would be posted with these line items or line edits shown. Okay, the second change is actually removing an edit that we put into the first draft. So it is not a change from the original version of the rule that's in effect now that we're currently operating under, and it doesn't change the process that we use on making documents accessible and available to the public. The reason, so we added the "and shall post these materials to its website" because that's consistent with current process. Whether it does not currently say that, but we do post all confidential materials to the website, and we would continue to make those available to the public as it's stated in the rule. We are just recommending removing this edit to give us more flexibility in how materials are made available, and also to be consistent across regulatory processes. This is not in other rules for rate review and hospital budget, for example. We still make those materials available. We'll continue to do so and want to be consistent across regulatory processes about how we do that. Okay, so those are the two changes. The next steps are that after the public meeting today and at the end of the public comment period on January 23rd, staff will file an updated application complete with any changes to the Secretary of State and the Legislative Committee on Administrative Rules. Again, the amended rule would go into effect July 1. There were 2 public comments through the course of this process, which have been addressed in previous meetings on the rule by Michelle, and taken into account. We have received no additional public comments. So before I turn it over or back to you, Chair Foster, next there would be any board questions or comments and public comment. I do have proposed motion language if you wish to vote. And again, the public comment period is extended. You could still vote today. If anything came up in the public comment, we could bring it back to you. We would still review all of those, but the vote could be completed. But up to you how you would like to handle the vote. And I think, yeah, the final slide is just an overview of the statute and the changes. And for accessibility requests, you can reach out to Kristen LaJeunesse in our office. So I will turn it back over to you, Chair Foster, and thank you.
Thank you very much, Marissa. I'm actually going to make the motion and then do board comment and public comment. Could you pull up? Yeah, thank you. After consideration of public comment, well, actually, sorry, I'm going to modify the proposed motion and we'll consider public comment after the motion's read. I move to modify proposed GMCB Rule 5.0 as follows, as recommended today by GMCB staff. 1, modify sections 5.103 and 5.104 to include a de minimis exemption, and modify section 5.106B. These modifications shall be included in the final proposed rule filed with the Secretary of State and with LCAR.
Second.
I'll second.
Thank you. And I'll open it up to board member discussion and deliberation on the proposed motion.
I just have one question. Maybe this is more for legal than for Marissa, but
Dave, I'm going to stop you. If it's a legal question, we need to go into executive session. You shouldn't ask legal questions publicly. So if it is, if you have non-legal questions, let's do that here. And if you'd like, we can take a break and we can talk about whether or not it's a legal question.
well, I guess I'm just trying to interpret the rule, and I have a hypothetical scenario, and I'm trying to figure out whether or not that would be an exemption. Sorry, whether or not an entity would qualify for the de minimis exemption.
I think interpretation of the rule and application of the rule would be legal advice.
Okay.
Maybe Marissa can do it in a. Why don't we do it through legal advice? Because that sounds like it would be legal advice to me.
Okay. That's all I have. So.
Any other public comment? I'm sorry, board member discussion or comment? Okay, I will take public comment and I'll start with the HCA.
Hi, my name is Eric Schulteis. I'm a staff attorney with the HCA. I just want to note that it's difficult. I appreciate that the board's already, we've talked to the board and commented on this rule. I think taking matters of interpretation of a proposed rule as legal advice shields public knowledge of what the board thinks it's doing. So I guess I would question whether that is an appropriate matter to take into executive session. Thank you.
I would respectfully disagree that the board is entitled to get legal advice. We get legal advice routinely, and it's important for us to understand the legal implications of our rules and statutes. It is not appropriate for the public to receive our legal advice. We would blow privilege there by doing that. So I understand the interest, but it's not appropriate to do that. Any other public comment? Okay, given that there's an outstanding question, it may be legal advice. I'm going to take a quick 10-minute break to connect with our lawyers and potentially see if we can set up an executive session if need be. So we'll take a 10-minute break and come back at 11 a.m. Okay, we can resume our board hearing. We took a break to discuss with council a couple questions, and I'm going to make a motion that we move into executive session. So I move to make a finding that premature general public knowledge of confidential attorney-client communications would clearly place the board at a substantial disadvantage.
Second.
All in favor of the motion, say aye.
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 Aye. Motion
Aye.
carries. Motion carries unanimously. Second, I move that we enter into executive session pursuant to 1 VSA 313A1F for the purpose of seeking counsel from GMCB's attorney staff. Attendance of the executive session will include the board members, counsel, and necessary GMCB staff.
Second.
All in favor, say aye.
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 Aye. And the motion is approved. We can resume the public session. There is a pending motion on the floor, and I think we are ready to take the motion up unless there's any other public comment at this time. Seeing none, I'll take a vote. All in favor of the motion, please say aye.
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 Aye. Member Walsh, I didn't hear you. Did you vote?
Yes. Aye.
Great. Okay. The motion carries unanimously. Thank you very much, Marissa, for working on this adjustment to the rule. I think it's an important one, and you and our legal team did a great job. So thank you very much.
You're welcome. Thank you.
Thank you. I'll turn to our Health Systems Finance Director, Matt Sutter, and he will introduce the Brattleboro Memorial Hospital update.
Thanks, Chair Foster. Give me a moment to get some slides up. So I'm going to walk through just provide some background context about the issues we've seen at Brattleboro Memorial Hospital and provide kind of an introduction to Mr. Sandville's presentation that'll follow. So I'm just going to give a quick background, timeline, summary of issues, give some high-level updates, looking at the P&L, comparing the projections they sent in July for FY25 versus the actuals, and then take a look at their budget resubmission versus their originally submitted budget. So I'm not going to read everything here, but I did want to provide a timeline for some of the issues that we faced or we encountered last year. So in general, it was a cycle, right? Brattleboro would fail in meeting reporting deadlines or submit material with significant errors. Staff would provide technical assistance. There would be a period where they'd update their numbers, and then there would be continued issues. We'd find new issues or existing issues would remain, and then we'd reach back out and the cycle would continue. It's not unusual to have some technical issues or provide support to hospitals in submitting materials to us. We do ask for a lot, but the errors we were encountering weren't like appendix type forms that weren't tying out. They were very fundamental financial statements that really didn't make sense. So balance sheets that didn't balance, revenues not carrying over to the income statement correctly. In addition to this, DEVA could not true up their provider taxes without accurate reporting at a more granular level than the audit provides. So we were having some challenges from a number of different angles last year, and these challenges and difficulties carried over into their FY26 proposed budget submission. So they submitted that on July 1st. My team spent a significant amount of time trying to reconcile their submission and met with them in early July. I think it was July 9th, to understand and correct the issues. And at that meeting, Brattleboro informed us that their staff knew those issues existed when they submitted their budget. So despite these issues, Brattleboro formally requested exemption from a budget hearing in late July. Staff did not recommend this request to the board, and the board did not grant it. During their budget hearing, there were numerous questions and concerns about both their budget and apparent inability to submit accurate financial statements. The board did not allow any increase in NPR over previously approved levels, did a level funded budget because we couldn't make heads or tails of their submission. However, a 2.4% rate increase was allowed due to solvency concerns. That 2.4% was below the benchmark of 3, but it reflects kind of the average approved or SAP recommended rate increases once you back out UVM medical. In addition, the board also ordered BMH to submit an approved FY26 budget that corrected material errors and to resubmit corrected and accurate FY24 and 25 operating results. Failing to do so would result in a potential hearing to consider whether it's necessary to appoint an independent observer. So really quick, were there red flags? What red flags did we see in their budget? So there wasn't a single thing. There was a combination of increasingly poor financial performance coupled with late, inaccurate, or in some cases inexplicable reporting. So some examples, right? We saw very high and increasing days accounts receivable, suggesting revenue cycle issues. On that, we also, had issues in reporting some of those A&R numbers. There were dwindling cash coupled with regular operating losses. So we didn't see evidence of a recovery down there. Some of the reporting was so inaccurate on its face that we just knew it was wrong. So net Medicare revenue being negative for FY24. As I mentioned, there were later missing reports, selective answers to some staff questions, ungrounded budget assumptions, such as Act 55's outpatient drug cap not applying to them. These were all just kind of red flags that there were issues with their budget and financial submissions. Since the budget hearing, there's been significant changes to leadership at BMH. They've hired a consultant to uncover issues at the hospital and correct financial and reporting issues. These updated financials will give the hospital leaders, the GMCB, and Vermonters a more accurate picture of the hospital's financial position. So very quickly, I know Mr. Sand will walk through probably in greater detail, but I just wanted to kind of compare some of the changes from what we had in the summer. So the column on the left, you can see their FY25 projections that they submit in July. Had a negative $2.8 million operating loss. Their updated actuals that they submitted is $1 million worse. However, this is more worrying than the bottom line would suggest. If you see their NPR, it's actually a $5 million decrease versus the projections they gave us, offset by kind of one-time grant funding, kind of papering over those losses. So worse than the $1 million deterioration would imply. If we move to FY26 submission, their NPR is about $5 million less than they originally submitted, but more impactful to their bottom line is that the operating expenses are projected at $9.3 million over. Combined, this results in an almost $15 million deterioration versus their original submission, in very concerning double-digit operating margin losses. So next steps, due to issues, like I said, with their budget and financial filings, the FY26 budget order anticipated the possible need to appoint an independent observer. Because they've engaged consultants to improve both the reporting issues that are being discussed today and underlying operational challenges at the hospital, staff does not currently find a need for or recommend appointing an independent observer at this time. But next, we'll have Mr. Sandville at BMH will update the board on their resubmitted budget and discuss some of his findings and strategies for improving hospitals' finances. Chair Foster, that's all we had in terms of a staff introduction. I'll pass it back to you.
Great. And I see Mr. Sandville here, I believe. Hi, Mr. Sandville, how are you?
Good, thank you. Good to be here.
Well, and I'm advised from staff you have some comments and information to share with the board.
Yes.
Okay, please go ahead.
Okay, I don't know if Matt's going to put up the slides or.
Happy to. Yep.
Yep. So we just put something. I wasn't really sure exactly if this is a budget hearing or what. So we'll just provide some information, and I'll do my best to accommodate your questions and concerns. And then I believe that we are scheduled next week for a follow-up, which would include one of the interim co-CEOs from BMH as well as myself again, and we'll clean up any outstanding questions or issues next week that may come up in this session, if that's acceptable to you.
That's totally fine. Thank you. Thank you for making yourself available today. I know we couldn't have the CEOs here today.
Yeah, we just just scheduling snafu, and frankly, I'd rather have the doctors seeing patients right now, and but they're available next week, so we'll make that work.
Great.
So just some of the leadership changes that Matt referenced earlier. So Dr. Tony Blofson, who's a primary care physician, and Dr. Elizabeth McClarney, who is an orthopedic surgeon, were installed as interim CEOs probably almost 3 months ago now. And then I was brought in towards the end of October to provide some consulting and advisory services to the Board of Trustees and to management. Subsequently, with some additional turnover, they asked me to be interim and fractional CFO, and we brought in a senior financial director from Ovation named Patrick Nudo. He was instrumental in developing our budget. Typically for hospitals, it's a 3+ month slog to produce a budget. We did it in about 3 weeks. We pressure tested all of the prior assumptions. Patrick met with pretty much every department manager. We scrutinized all of their judgments and then produced the budget, which we submitted basically Thanksgiving weekend, and sent a narrative out on the 1st of December. Next slide, please. So one of the founding principles of developing the budget was, what is the operational reality of BMH for the last several years? So we did a quick run rate over time, and you'll see the reported operating gain loss bounces around, mostly negative. But what's not illustrated in that is how much of what we termed extraordinary offsets. So, 2020 COVID money, 2022 additional COVID money. So we've kind of, that doesn't reflect, while it was justified in the pandemic, it doesn't reflect what they were operating at for efficiency. So we removed those and then, ran that out again. And you can see that there's only 1 year in that range of dates where they produced a positive operating margin. And the average loss over the 9 years sampled was $5 million a year. So what they're experiencing currently was not birthed in the last year or 2 years. It's been an ongoing thing for Brattleboro for many years. Next slide. So one of the key mandates from the co-CEOs was, we want to know who we are financially right now. And so when we built this budget, we built it based on everything that was true factually in the moment, and anything we knew was going to change factually in the future, meaning the fiscal year. So several years ago, your esteemed colleague Jessica Holmes questioned a budget I submitted and said, is it aspirational? And I told her I put the ass in aspirational. But what we did here was remove any aspiration so that we could get a true measure of what was likely to happen during FY26. And as we went through that process and got down to especially some of the larger items, we had to sit as a senior management group and determine if there were things that we knew we could change, that we could commit to changing. And so there's literally no positive or negative aspirational type entries in this budget. This is who we are operating at. And I'll say that the negative $14.5 million operating margin was far from anything anyone wanted to see. But that said, as we're closing out FY25, we're with audit right now with Barry Dunn, we're probably going to come out to about a negative $15 million operating margin, give or take. Still some things up in the air right now that are material. So that to me said the $14.5 million projection for FY26 is likely to be a solid number given everything we knew at the end of November. So quickly going through this, we've had diminishing volumes in the medical practices over the last few years. We all had things that we thought could be done, but we weren't sure that we were able to deliver on those. So there are initiatives already underway in the clinics, and we've seen a bump up the last 2 months in clinic volumes, but that's the trend we were on. There was a significant reduction in gross and net revenues. We contracted with a new vendor to provide emergency room professionals, and they're going to be doing the billing for their services. And so that came off the table from a prior budget to what we submitted this time. Inpatient volumes are down. Therapies are down mainly because we're having difficulty obtaining staff in those areas. Diagnostic imaging was up slightly. OR was basically, I neglected to put that on the slide, but OR was essentially flat. Lab and pharmacy volumes also relatively flat. And we'll talk about the impact of Act 55 later. And then oncology, medical infusion. We have some provider transitions that we knew were coming in FY26. We're having an extremely difficult time replacing the oncologist/hemonc at our level. We were contracted through the Dartmouth system to get oncology services. They've had a reduction in their staffing and have had to pull back those folks. And so we're not even sure that looking forward, we're going to actually have the medical oversight needed to provide those infusion services going forward. Next slide, please, Matt. So one of the areas that was not reflected in the original budget that is a reality, an unfortunate reality for Brattleboro at this time, was the Act 55 120% cap issue. It's going to reduce our gross charges by nearly $14 million. And obviously, we're going to lose some commercial NPR on that. Medicare and Medicaid are really not a material change relative to reimbursement. But historically, BMH only marks up the pharmacy costs 200% from our actual acquisition costs. So those are managed on an ongoing basis. Next slide. 340B program. As of print, time of print for this budget, we had received notice that the CMS measurement for our Social Security ratio was half of what had been historically. We believe that is a mistake. Our payer mix and our patient demographic hasn't changed from prior periods. And we have had to contract with an outside entity to help us build a case to have that reconsidered. We expect that once if we're not able to overturn that data on appeal, then somewhere around March or April, we will lose the benefit of 340B, which will increase our acquisition costs for about 1.7 million, and we will lose our contract pharmacy 340B revenue to the tune of 1.3 million for 6 million over the last 6 months or so of the fiscal year. So it would be 3 million and a half a year, but 6 million next year. So at this point, we've got about halfway through that study with the outside entity. I actually have a meeting with them scheduled for tomorrow to check on progress. But it looks like we may be able to reverse that. So we would be, in theory, putting $3 million back on the table. Next slide, please. So bottom line is, we believe that the budget we submitted to you folks is compliant with all of the terms of the order that Brattleboro received with this revised budget. In fact, we are well below the cap established for net patient revenue at set at 113, and we're coming in at 111. Relative to expenses, so you'll see there's a pattern in this, and we can talk about some other observations and things we've learned over the last few months. But there's a lot of stuff that goes on that hospitals are required to carry that don't always make sense, but in the sense of providing the necessary care to our community and keeping patients safe and providing adequate access, we're forced to carry those. One of those is making sure that we have round-the-clock pediatric coverage for the birthing unit when babies are born. That cost is about $500,000 a year. And with a diminishing volume of births statewide, nationwide, and certainly in the Brattleboro service area, that becomes less and less tenable for the organization. We did a contract with a new ED clinician group and new anesthesia group, and that's going to cost us an extra $400,000. Those items were not included in the prior budget submission. We were able to remove a lot of one-time and non-recurring consultant costs previously included, but we also added, that was about a 1.5 million, and we added back about $1 million because frankly, we have a lot of work to do at Brattleboro, and we have limited bandwidth with existing staff and management. So we added back $1 million for that. It should be noted that we did apply for the provider stabilization grant. We applied for $2 million to address specific areas and operations that we think we need external bandwidth to assist with. So that may offset some of that $1 million, depending on how much is approved and assuming it is approved. The drug expense line is up 1.9 million, mainly because of the loss of 340B status. Again, if we're able to reverse that decision in the next month or so, then that would become more of a moot point. I'm sure your inflation discussions with other hospitals during the normal budget process would reflect something around what we grabbed, which was a 6.4% increase on drugs in general. Labor, and I'm speaking in generalities. I'm not speaking to each and every department, but BMH is over market for wages, benefits, and staffing levels for like hospitals. Based on reading the budget activities from August, September, I don't think that's a surprise to anybody at the Green Mountain Care Board. But what we did put in that budget for FY26 revised was a 0% wage increase that was included in our narrative with that submission. Additionally, a reduction of 403B contributions, and we are planning a mid-year, for lack of a better word, reduction in some of the benefits that we're offering our folks. It's important to note that that is all subject to ongoing union negotiations, but that's what we feel like we needed to do in order to take steps forward in getting back to solvency. Go back, I'm sorry, Matt. The employee benefits in the prior submission, this would be one of the areas that was aspirational. BMH was running hot on their self-insured benefit plan. Year to date, that was not reflected in the prior submission. For the revised submission, we reflected the current run rate in the FY26 spend. So that was an increase of 3.5 million over FY24 actual for FY25, and even more in our revised submission. And then one other thing that we did that was different from how things were submitted, and this is something I've done at every hospital I've worked at. I always budget the necessary FTEs to provide the services required, and then I factor in a differential for the cost differential between FTEs and travelers in the areas that have historically used travelers. The reason being that our goal is to get to 0 travelers, which I guess is a little aspirational, but we're working diligently to reduce that. The impact that has on this budget is that you're going to see more FTEs than what was submitted previously. But in total, the workforce is net 0 with that submission. Next slide, please, Matt. So, the bottom line is the new budget rolls up to a loss of 14.5 million. We have one positive thing that could happen, which would be the 340B, and would help us for the remainder of FY26. We've measured the full impact of all known issues and all things that we've committed to at the end of November. And this was reviewed and endorsed and approved by the senior leaders, as well as the Board of Trustees, who have been extremely engaged over the last several months. So open to questions, comments, requests.
Okay, thank you very much, Mr. Sandville, and I'll open it to the other board members for comments and questions.
Did somebody
I
jump
have
in
a
there? I
cou-
wasn't sure if I heard somebody.
I don't think so. Go ahead, Jess.
Oh, okay. Mr. Sanville, it's very nice to see you again. You've been missed in our meetings, so it's nice to see you, and thank you for stepping in and helping out here.
You're welcome.
A quick question for you, a couple quick questions. I'm wondering if you can talk a little bit about the impact of the Rural Community Hospital demonstration project on, what was expected from that, what is materialized from that, particularly relative to the Medicare dependent hospital low volume adjustment status that was there before. Just can you talk a little bit about that, because it did come up in the hearing last summer?
Yes, I'm gonna actually talk very little about that. I'm gonna take your talking a little about it, and I'm gonna double down. To be honest with you, I've only done a cursory review of that program, so I'm hesitant to say anything here at this point that would be said out of mostly ignorance. We focused on getting that budget done and looking at the reimbursement, and I have some numbers in my head. I don't know if they're actually accurate, but I would be happy to bring that back with fleshed out a bit next week when Dr. Blofson presents with me. and talk about that. That's a program I have not participated in historically. I have some familiarity with it. We ran some numbers at the time of budget, but I would be speculating today, and it would be not wise for me.
Totally
How
fair.
blunt and
That's
honest
great.
I am. So
I do. No, and I appreciate, I've always appreciated that, and I appreciate that now. That's fine. Next week is great. A second question was, and it was mentioned in the letter that that BMH had applied for and received AHS's hospital transformation grant money. And I'm
Yes.
wondering if you can talk a little bit about what you specifically was applied for, what kind of technical assistance or programmatic changes, and where that's at, how much money.
Yeah, we received $156,000, and again, I'm happy to provide like just a quick slide next week with specifically what was entailed there, but I'm going to give a high level that I'm fairly comfortable with. We're looking at studying and looking at the patients that we transfer in and out of our facility, and whether or not there can be people who can be kept. And what would it take to keep them? There's also some services or some areas of that grant related to one of the 28 projects that I'm currently running at Brattleboro to look at various areas of staffing as well as access and quality. So there's your four high level things. And we do have a budget for that was submitted and refined actually last week. So as we work through those deliverables, so I'm happy to put that on the list as well.
Great. And I just actually wanted to ask a little bit about what you're learning about the volumes declining in the medical group. That was one of the points on the slide, but you actually also mentioned that there are some changes in the clinics such that maybe that trajectory is changing. I'm just wondering what was driving volumes down and what is happening now to try and recover some of those volumes.
Yeah, I think there was all the docs working on, I don't care if they're on Epic, Cerner, you pick the EMR, they're all largely disappointed with the documentation and workflows associated with those EMR products. I heard someone say the other day, Epic, every provider is confused. And so I was like, okay, and that's pretty typical. And so we have a few people really working hard on patient workflow. We've adopted a new documentation product available from Cerner. We've rolled it out as a trial, and now we're rolling it out to more providers, which is basically an AI assist, for lack of a better word. And the term that I've heard in multiple meetings over the last month and a half is life-changing. So it still requires them to review the note that's produced, but it is helping us with throughput. The other issue that they're addressing aggressively is our no-show rate was higher than what I would consider to be normal in our region. And so they've made some software changes that are like ongoing as we sit here today, unloading one vendor that was doing confirmations and bringing in a more integrated vendor with a better implementation plan. So we expect that to go down. And we're experiencing that on the hospital outpatient side as well. But the last 2 months that we have closed, so October, November, they have exceeded volume expectations. So we're already starting to see results from that initiative.
Okay, and this is probably a related question. It's my last question, but I know you had, or the letter had talked about productivity benchmarking, and I recall productivity rates as measured by work, RVUs were on the lower side. But I also heard you say that analysis suggests that you're over market for staffing, but that inclusive of travelers, the budget assumes net zero on staffing. So I'm wondering if you could just talk a little bit about productivity, staffing, over market for staffing, and how that manifests in the budget and the expected recovery for BMH.
Right. So, so I've got to think about how I say this. So I'm tiptoeing around things like NDAs, separation agreements, union negotiations. So those things have to be. We thought we kind of could have identified some areas that we could have adjusted in that budget, but we couldn't commit to them because there are other parties involved in those discussions. So what I can tell you is that BMH had invested in last year, I don't know specifically when, an add-on piece of software that inputs FTEs and productivity measures on an ongoing basis, and allows you to set goals for each department and establishing, based on a cohort measurement, benchmark measurement for like size facilities. And then there's a pilot project that has been started since FY26 began, where they are looking at that and piloting that with a few departments. There were some input issues in that are being cleaned up. So, volume being attributed to incorrect departments, or, things like that would normally happen with implementation. And we're working on cleaning that up, but directionally it's pretty close right now. And the pilot program has begun to make those adjustments. And believe me, Brattleboro will be very happy to report on any progress they make in that regard.
Well, I appreciate the candor and all of the hard work you're doing. So thank you so much.
Appreciate it. Nice to see you again.
Nice to see you.
Other board member comments or questions at this time?
Can I just add in a few more? Share Jess's appreciation for you digging into this. It's nice to see you again and hear your voice. A couple questions. So just looking, broadly speaking, it looks like expense growth has exceeded revenue growth for a number of years. And I was just wondering if you've been able to identify clearly any expense drivers that seem disproportionate at BMH that that are areas to address.
Yeah. So the big ones, if you look at a P&L, the big ones are like your all costs associated with the human resources needed to deliver care, right? So salaries, benefits, retirement, all of that stuff. So we've talked about that. Another thing that we're heavily investigating as we sit here would be we're not sure. Well, we are sure. We're sure that we're not getting all of the revenue through our AR management, which I think you guys noted in the order, and so we are in that process of cleaning up the source data so that we can be reportable. We have a disproportionate number of denials and the like, and so that's really our next bastion of revenue improvement without changing pricing. So that's kind of begun to be underway. We've got a ton of work to do there. There are 2 groups currently running projects in that area, and that's kind of a large offset that we probably have not been getting what paid for the work that we're doing.
That's actually super helpful. That was my follow-up question, was the AR process. When you look at that, do you know if the denials come from particular subset of payers, like say Medicare Advantage, for instance, and the potential impact of MA leaving Vermont, or do you have any?
Right now, we're at the Yeah, right now we're at the point of why are we getting denials and what do those denials look like? We didn't get pre-authorization. There was a coding issue, untimely filing. I mean, so far, most of it's, to be frank, is seemingly more on our end than the payer end. And so we haven't broken it down to the payer level. We just categorize all the types of denials we're getting and identifying, who's the culprit in that in that broken process, and and what is it valued at, like that particular type of denial. And then the next step would be to, to determine the root causes and then to figure out, obviously, getting a denial from Cigna for a given service is a lot more valuable than a denial from Medicaid. So you're about 2 levels down on where we're at in the programs that we're running right now.
Yep. Thanks. And the other question I have for you is on the medical infusion Act 55. You said that typically Brattleboro does the average wholesale price plus 200% or 200% of the average wholesale price?
So average wholesale price doesn't really translate to our purchasing pricing for a couple reasons. One, if you're a 340B eligible organization, you're buying at 340B pricing, which frankly has nothing to do with that. As you can average the percentage purchase cost as a percentage of ASP or AWP, but they're not, each individual drug is not the same amount off on pricing between those two standards. And then moving to out of 340B, we're going to be forced to go strictly through our GPO, group purchasing organization. And that is going to be higher on the average than the 340B pricing. And so that is what we used, tailored by the 120% cap. So it's not simple math. It's actually 3 or 4 level math to get down to proper pricing. But we have historically priced our meds at 200% of our acquisition costs, and we look for the best acquisition cost from whichever nation we can get it from.
Okay, that's helpful. Thank you.
All right, anything else at this time for Mr. Sandville?
I have one question, Chair Foster.
Please.
It's about, you spoke briefly about difficulty hiring oncologists, I believe, and I think it was for outpatient oncology. Is there a connection between those and the cap on ASP? Are you going to lose money just because you don't have the doctors to infuse the drugs versus the price that you're able to acquire and charge for those drugs?
So as we sit here today, there are no oncologists available to us unless we go out and hire a locum, which is extremely pricey, right? So when we contract with Dartmouth, it was basically cost plus for them. They were very reasonable in their pricing with us and fair, but that's not available. We even looked into getting a mid-level, allied provider who specialized in that, nurse practitioner, whatever, to work in conjunction with a telehealth MD, right? So we've tried a couple different ways to look at this, and right now there's no availability. And the concept of hiring, a couple day a week locum, cost prohibitive to begin with, and then you throw in the Act 55 issue, and it even becomes less affordable for us. The concern we have is geographically, we feel like that is an absolute community need. And when you start looking at drive times, so right now, as we understand it, Cheshire, for example, they can't take the patients. They're the closest. Springfield cannot take the patients. Grace Cottage cannot take the patients. So now what? You're driving to Southwestern. We're going to put our sickest patients in a car and send them up to Dartmouth. It just it's untenable for our community. So we are still scrapping, trying to find a way to solve that problem, regardless of Act 55, but certainly that's not helping.
Great. Thank you for elaborating on that. I appreciate it.
You're welcome.
Okay. Any comment from the healthcare advocate?
Sure. David, thanks for coming back. And I always, as in when you were out of Scotney, I deeply appreciate your honesty and forthrightness. It's quite, or frankness, it's quite refreshing. So I was wondering, you mentioned, that this problem has been a long time evolving. And I remember back in, God, it must have been on the 2018 990, and then some, not the top line things like NPR, but like subcategories like uncompensated care. There were, in actuals, there were freakish variations, like all of a sudden things would jump 20%, and you're like, well, that can't. And we couldn't figure out a reason why that was happening. And I'm still wondering, like, would it have been possible to see the early signs that there was a problem? Like are there numbers we could look at if there are huge variances that would kind of be a canary in the coal mine?
So the answer is yes. The short answer is yes. Again, I don't need to be fired on my this afternoon, but so I'll back up to this. How about this? So they called me, and the board of trustees called me in mid-October to come down and do an assessment, and so I think they were a little frustrated because I actually didn't want any P&Ls or balance sheets or anything like that. I just wanted to talk to people, which I'm good at. So I talked to people from 9 a.m. till 7 p.m., half-hour increments all day. Senior managers, board of trustees, middle managers, whatever. And my observation was you would often get different numbers from different people for the same thing. You would get different impressions of the same number from different people. So I say all that to say that they have a good IT infrastructure platform. So they are on Cerner primarily for EMR and Multiview for a financial package. I was on that at Mount Escutney for 11 years. Super low audit adjustment numbers, like my audit adjustments annually probably averaged at 1. And part of that was we had good staff, but the other part was we set up the systems really tight. And so I know what they have can work. I brought in somebody to do a little work for me, a day a week for a few weeks to look at the integrity of the financial reporting system in particular. Financial reporting is always affected by interpretation, correct? So how we look at things in the hospital is not how it translates in adaptive all the time. There's nuances, and Matt, referenced that earlier. So they have that same kind of issue internally. So we're looking to clean up all of the standardized reporting. And again, it balances every day. I mean, it's just things aren't maybe attributed to or easy enough to attribute consistently in the same way. So we're cleaning that up, which will obviously help with our submissions to you folks in the future. But more importantly, will provide better information internally, which ultimately ends up externally in 990s and whatnot. So, and I think they had a great deal of transition in financial staff for a number of years, and so all subject to interpretation. And so it's messy. It's not incorrect. It's just messy. And so we're looking to standardize all of that. One of the initiatives we've got working right now. And so, yeah, there should have been some red flags. I'm not sure. I wasn't there, so I don't know what was or wasn't asked about or pushed back on. But what I can tell you is the board is very engaged now. They are pushing me a bit, which is fine. And, we'll get it cleaned up and consistent. Nice to see you again, Eric.
Nice to see you too.
Great. Any other public comment at this time?
Walter had his hand up at one point.
Oh, Dave, careful, I'm gonna make you chair here. Might not be as much
Hey,
fun as your
Dave.
job.
Hi, nice to see you again, Walter.
Hey, Dave. Just a small point, but one that we always forget. When you say payers, please remember that we are the payers and not this plethora, mishmash of health, of insurance companies, public, private, and so on. So they're really taking our money and denying claims with our money. Please remember that.
Oh, I remember that on a daily basis, Walter. Two things for
Good.
you. Number one, private and commercial insurance companies are not in business to pay claims. That's not how they make
I know.
money. So,
I know that very well. Very,
and-
very well. I almost
and-
died because of a private insurance company. I know that
Sorry to
very
hear that.
well.
and number two, I come at all my time with the Public Oversight Committee and the Green Mountain Care Board. I come at my job every day and these presentations from the perspective that I'm not just a hospital CFO, I'm a consumer of the system, I'm a taxpayer, I'm a father, husband, grandfather, and unfortunately I'm a little old. But, that's how I look at all this stuff to the best of my ability. I try to thread the needle on all of those priorities.
Consumer is another word I hate, but you know why.
Thank you, Walter. Any other public comment? Okay. I do have a comment, but I think I'll wait till there's an opportunity for the new CEOs here. I do also, like Jess, appreciate the changes that were made to deal with these issues. The timeline that Mr. Sutter walked through, I think, is alarming and very, very concerning. And sitting here walking through it, I have some pretty strong reactions to this episode and what happened. And I do need to make comments about how I at least anticipate dealing with it next time. I don't think it's really appropriate for the board to solve financial problems necessarily with commercial rate. And if a hospital submits inaccurate and incomplete, knowingly inaccurate data, I don't know that we should be giving rate increases at all. It's just a bad precedent to set. I did vote for it this time in this situation, but we're going to have solvency issues at our hospitals. This is not a surprise. We've said it for 5 years, maybe 6 years, and we did it in what I think is sort of exceptional in this situation. But I don't want the industry to think that that's going to happen again. I'm not sure that it will. It's fact specific, but this wasn't a great history. I'm glad that the changes were made to correct everything. And I commend the board. I spoke with the board. I spoke with some of the leaders that things are changing, but I do need to make a point, and I will make it next week, that should not be an anticipated practice. And I don't view this as a precedent. I view it as an exceptional circumstance. We want Brattleboro to strive. We want Brattleboro to thrive. It is a hospital that we have supported. And it's a hospital that in the Oliver Wyman report was identified as one that should be here and is one that's important. But first and foremost, the solution to make sure that happens is the management and the board needs to identify the essential services for that community, and it needs to come up with a plan to pay for them. It is not on the board and it's not on ratepayers to do that. We know we're going to have service line changes. So the management and leaders need to double down on what has to be there and then find a path to pay for it. And I'll make those points next week, but I just did want to flag them because the timing and the staff, the work that's put on staff is really disruptive to the rest of their work. And this was not a great episode. But that has nothing to do with the team here now. So I do want to flag that that's historical, but it is important to flag. Anyway, I'm going to, it's 12 o'clock now, and I appreciate the time. Mr. Sandville, likewise, greatly appreciate your candor and your approach very, very much, and the new leadership and the board's engagement. Any other new or old business for the board today? Great, then I will move that we adjourn.
Second.
All in favor, say aye.
Aye.
Aye. And the motion's approved. Thank you, Mr. Sutter, and thank you, Mr. Sandville. Everyone have a nice day. We're adjourned.